recording has already started, and that will be used to do the minutes and be available for anybody who missed the meeting. We've got a very full agenda, so we're trying to limit it to 10 minutes per item if we can, so that we're not here all afternoon because the sun's come out. So some of us might want to do something else. There's a number of discussion items, and we need to bear in mind the COVID-19 recovery as we talk about things. And then we've got a regular update from Sir Chris Ham on the Health and Care Partnership. So I'll try and make certain I get you all. If you want to ask a question, you can use the hands facility if you've got it. If not, if you can use the chat, and myself and Paul will try and make certain we don't miss anybody. So if we can do that, and then if you're not speaking, can you mute your microphones, please, because that will make the system work a bit better. So if with that and your approval, I'll move on to the main agenda. And apologies, and I have Councillor Margaret Bell, Andy Hardy, Councillor Joe Barker, Dame Stella Manzies will be late, and I'm not saying whether we have apologies from Dr. Sarah Raystrick. Paul, do you any different to me?
Chair, just to add to that overnight, and forgive me if I duplicate any of those, I know Councillor Dave Parsons has submitted his apologies as well for today. I think, Chair, you've covered all the others. Thank you.
Thank you. Can I ask members to disclose any issues of pecuniary or non-pecuniary interest, please? No, we'll take that as read. And so if I can just do a general introduction, is that, as I say, it is our first board, and our next one will be January. And I hope you'll approve the progress we've made and the reports we've got to show that we are still working. But I also need to mention Simon Gilby, who's been a stalwart of our committee and the Health Wellbeing Board, and this, I believe, will be his last meeting before he retires in January. So we need to thank, and very much so, Simon for his input. And I've been working with Simon for a long time, first with scrutiny and adult and health scrutiny. And when I was chair of that, and I need to thank Cam for his sticking with us. It's been difficult at times, but I feel we are, under Simon's leadership, made a lot of progress, and we are still moving forward on mental health and making life better for the citizens of Warwickshire. So thank you, Simon, for that. I don't know if you wanted to comment.
Well, only to say thank you.
You're muted, Simon.
I've gone mute, yeah. Just to say thank you very much for those kind words, Chairman. It feels a long time before I actually go, but I guess if this is my last Health and Wellbeing Board meeting, I should acknowledge that. But thank you, and I can't tell you how much I've enjoyed the role and the privilege of working with all these exceptional colleagues around the table. So thank you, Chairman.
Thank you, Simon. Also, Rachel Barnes, who was our officer support, has moved into a new role within the authority in the change management team. So we welcome Gemma McKinnon, who's our new Health and Wellbeing Delivery Manager, and she's been supported by Catherine Shuttleworth, who's been not only doing the interim between the two posts, but is also working with us and with Gemma now. So welcome you both to the meeting. Thank you for your input, and look forward to working with you both. And we also have two junior doctors, Susanna Kaloin and Hardeep Galish, who are doing placements in public health and are sitting in on today's meeting and observing. So welcome to them. So the minutes of the meeting of our last meeting on the 6th of May have been circulated. Are we all agreed that those are correct? It seems a long time ago. Any comment, or can we take them as read? We take them as read. Thank you very much. If we could then move on to the health and wellbeing strategy, and Gemma will give us a quick update as to where we are. And then there's one or two things I want to say about it, and I know Russell wants to say one or two things, which I think we are general thinkers how we move forward with this and bring into mind everything that's happened in COVID. So Gemma, over to you.
Thanks, Chair, and good afternoon, everyone. So I'll provide a bit of an update on the current draft of the Health and Wellbeing Strategy and the proposed consultation timeline. So the approach taken for the strategy was endorsed by the board in January, and you'll all hopefully be aware that the initial priorities set within this were around helping our children and young people have the best start in life and helping people improve their mental health and wellbeing. Rachel Barnes had already undertaken a lot of engagement to inform the strategy through the Joint Strategic Needs Assessments and also the Senior Leaders Workshops, which took place last year and have been fed into the draft. The original timeframes for consultation were going to be between May and June. However, this was postponed due to the system focus on the COVID-19 response. Although priorities within the strategy remain the same, as the world has moved on since it was originally drafted, there are new pieces of information and findings that we wish to include. So this includes the COVID-19 recovery plan and also the findings from the Warwickshire's COVID-19 survey, which doesn't actually close until the end of September. So we want to make sure that we've captured these findings and that they're fed into the strategy, and so we're proposing that the consultation period runs between November and January, and my apologies because that wasn't reflected correctly in the paper. So we're proposing that the draft strategy goes out for consultation for a 5-week period, and there are a number of ways that we're seeking to engage with the public. So this will include an online questionnaire, which had already been drafted and is now being reviewed in the light of COVID. And we will make sure that there's paper copies available too. Then another way is through virtual engagement sessions, and these will replace the roadshows that we had intended to run. And then also through the delivery of presentations with partners. The COVID-19 Test and Trace Community Engagement Group that meets on a weekly basis will also be key to us for accessing and engaging with our community, so we can use those established links. So there'll be targeted engagement with key groups, and these have been identified within the Equality Impact Assessment, which Rachel had developed earlier on in the year. And again, this is now being refreshed to reflect any additional key groups to target that have been identified as experiencing the largest inequality during the pandemic, and also any changes to the consultation approach in the light of social distancing guidelines and measures. So the WCC marketing and communications team will support with communications, and then we're also asking for support from board members and wider partners to help promote the survey and the consultation documents through your networks too. So as I say, the timescales noted within the report did indicate that we would consult between September and November. However, we're suggesting that this maybe is pushed back, although I'm wondering if Les was going to say something different now, and allows us to feed in that further information, and also hope to ensure that we have enough time to raise awareness of the survey and hopefully increase its reach. So the recommendation to the board is for members to note the update on the draft strategy and to endorse the proposed approach to consultation. Thank you.
Thank you, Gemma. Russell.
Thanks, Gemma. I had just a couple of thoughts. First of all, thank you. It's a very well drafted as ever document, so very helpful. Can you hear me okay?
Yes, we're fine, Russell.
The aspect that I thought was just needing more of a dial-up in terms of the narrative is almost some of the learnings that come out of the COVID experience, which I think does affect our strategic emphasis. And in particular, if we look at the challenges we've had in care homes and looking after our most fragile populations or segments of our population. But also, I think there has been almost a paradigm shift. And one of the things we've talked about in the past a lot is how working together local authorities and the NHS providing more care at home rather than in a hospital setting, we can improve our population's health and wellbeing outcomes whilst reducing the costs of delivery for us as a system. And I would just like us to sort of emphasise that more, because that for me is the big prize for all of us. We know there are funding issues about who pays for what, but the big prize for the system's costs, as well as our population's outcomes, is if we can work with our communities, deliver more care at a home level and at a community level, rather than in an expensive, certainly hospital setting, and arguably even a GP setting. So it's just that bigger vision, which I know is embedded in some of the other documents, but I would like to see coming forward in our thinking. But we've done great things. You know, you think about the way the LGA used Warwickshire as an example of our COVID response, and it's just bringing some of that great stuff that we're doing and making sure it's applied over the next 5 years.
Thank you.
Yeah, thank you, Russell. I think the other point as well is we shouldn't just use what is Warwickshire County Council's recovery plan. If I know Swift has got a recovery plan. If anybody else has got one, perhaps we could have a copy, or Gemma could have a copy, and we can do some look at them collectively. I think they're pretty much the same, what I've seen of any, on the same principles, much as you've outlined, Russell. But it's good to look at those and see if we can incorporate them. And the other thing, I think it'd be good to let the place forums look at the draft when we've amended it. What I was hoping we could do, we could amend as soon as possible, email a draft to board members before it goes public, and then if board members are happy, we will get it out and do the consultations, and hope we can meet the timescale. If we slip, then it would have to be January. The other thing we need to think about, members, is sign off. We have a meeting in January, but that might be the last one till we've had the May County Council elections. In which case, would members be happy if we did a virtual sign off when we have a final draft that everybody's looked at, so that we can get on with the role? Looking for any other comments. Nigel.
Thanks, Les. I suppose a couple of things really. The first is that there is a health and care partnership recovery group, or reset group, and actually they met for most of today as part of a kind of a way day to focus on those collective kind of responses in terms of recovery and reset. So I think that is probably the best source in terms of the information, because it is a whole partnership from an NHS perspective with local government. There is also a recovery group which involves all of the councils, and I think that again there is a collective recovery kind of strategy. So I think there will always be others, and you know, I think any contribution is really welcome, but actually if we could bring those three together as the three key documents that inform things, that will at least cover the kind of statutory partners in this process. So I think that would be really helpful. I think the other thing I'd like to just do briefly is kind of endorse some of Russell's point, really. I think he's absolutely right about us looking at the things that we've talked about in previous strategies and in the the word's gone from my head now. In the Concordat, that's the word I was looking for. Some of those commitments about doing what's right for patients, what's right for residents, regardless of the impact on individual organisations. And I think some of the integration work that we've had planned, that to some extent has been put on hold during COVID, although not entirely, need to be a real focus for us again to drive some of those through, both as commissioners and as providers. And obviously we would want to be on kind of both elements of that kind of integration work.
Okay. Is that thank you, Nigel. Is there any other comment? In which case, can we take that as our our way forward. Are we all content with that? Anybody not? Good. We'll take that as our way forward. Thank you very much. Thank you, Gemma. Are you happy with that as a steer forward?
Chair, I think we've got a hand up. Is it Councillor Humphreys?
Married Councillor Humphreys. Sorry. Yep, you're on the bottom of my screen, not in the middle.
Sorry, I am in agreement with everything that's said, so please don't worry. But what I would say is, don't panic, Les. But besides the recovery after hospital, I would like to see the packages go in to stop hospital admission, because I think that's one of the big things that needs to be done as well. So, you know, the pre and the post admission, I would like to see the money going into both those. So I just wanted to add that bit.
Yeah, thank you, Marion. That's useful. Okay, we'll proceed as said with everybody's comments included. Thank you very much. If we could then move on to agenda item 3, which is update from our 3 health and wellbeing partnerships and their work programs. We've got it in writing. Is there anybody in the audience to speak on behalf of anyone from the partnerships, the chairs, or anything else? Okay. So we've had the papers of the 3 partnerships before us. Are there any speakers or anyone wishing to comment? Duncan?
Yes, it was just I can comment on the situation in rugby if you did want a
yeah, that would be useful.
Detailed.
Yeah.
Okay. Because there have been sort of quite a few changes this year since the last update to the Health and Wellbeing Partnership in rugby, and there's been sort of a significant transformation in sort of how we work together for the positive. I think the Health and Wellbeing Partnership has expanded to include wider partners from across the health services and beyond, and we've refreshed the terms of reference to strengthen the links back to the Health and Wellbeing Board, and also clarify the role of the partnership in supporting the delivery of a joint health and wellbeing strategy and the implementation and considering the new evidence that's emerged out of the joint strategic needs assessment programme. Similarly, in rugby, the delivery group has been established as part of a sort of healthcare partnership governance and sort of has quickly established itself with regular meetings through the COVID pandemic, and that's helped form that group, as well as its relationship back to Health and Wellbeing Partnership, and the 2 groups are now working closely together to develop a shared set of priorities to work on for rugby. The Health and Wellbeing Partnership is now chaired by Manny, of course, the Executive Director of Rugby Borough Council, who's taken over from Adam, and again that was another change to the Health and Wellbeing Partnership and sort of the way it was structured. This last year, again, the group has done sort of a lot of work around the joint strategic needs assessment and defining priorities, and you can see some of those priorities that have emerged out of the joint strategic needs assessment in the paper, and the work of the group in the last meeting has been to establish key themes, and the challenge now for the rest of the year is to use JSNA plus for recovery plans and health impact assessment, which we're talking about later, to sort of set out the action plan and the work of the group over the next couple of years. Other things that the group has done is considered the impact of smoking in pregnancy, and as well as clarified a lot of the roles and thinking around Halton and how we best sort of have discussions for that new development to ensure the health and wellbeing of new residents.
Thank you, Duncan. Any comment or any questions? No. In that case, can we take that report as read? That's great. Thank you, Duncan, and thank you for your involvement in all this work. So we could then move on to item 4, which is the Warwickshire Safeguarding Annual Report. And can I welcome Elaine Coleridge-Smith as chairman of both of the joint board to introduce the report and take any questions anybody may have. Elaine, the floor is yours.
Lovely, thank you very much, Les. Can I just mention that Amrita Sharma's in the meeting as well, and we may well take any questions jointly depending on what they are. Just really by way of background, this is the first report of the new partnership arrangements that came into effect in September 19. The new arrangements in Warwickshire replaced the old Warwickshire Safeguarding Children Board, which was closed down effectively as a board by the government, and also the Warwickshire Safeguarding Adults Board. In Warwickshire, we chose to bring these two big areas of work together under the leadership of a Safeguarding Executive Board for both adults and children, comprising the three statutory partners from Warwickshire Council, the CCGs and the police. We have retained two partnership boards, one for children's and one for adults, and we usually bring these partnerships together to look at safeguarding issues across the spectrum of adults and children whenever we have got commonalities and themes that work in that way. And we've also introduced quality learning and improvement hubs to work across both the adult and the children's agenda to really help us ensure that we are fulfilling our responsibilities around audit and challenge and scrutiny, and of equal, if not higher importance, the sharing of information, learning and establishing how well changes in practice have been implemented. Our focus, I suppose, in this last year has been around not only protection, but also around the prevention agenda, which ties in very much with the work you're looking at in your strategic oversight and view. We've also focused very heavily on exploitation, and we've this year to pull together all aspects of exploitation, from child exploitation that we knew quite well around CSE, all the way through to the issues in adult exploitation, and looking at it as a total area of concern for us to improve and learn. We've put a lot of focus, as I've said earlier, on including and improving the way we addressed audit and the way we communicated learning and information sharing, and the way we improved our ability to challenge and scrutinise the work of partners. Looking, I suppose, at our new quality assurance framework that we've put in place, one of the things that we wanted to do here was to have the opportunity to carry out in-depth reviews of issues of interest and concern. There's been a tendency with safeguarding boards previously, I think, to try and undertake a lot of audits and actually not really get to the hub of what some of the issues are. So we've set ourselves the challenge of trying to look at 3 or 4 thematic reviews in some depth each year. And the first piece of work that we looked at focused on exploitation of children and adults across Warwickshire. This was a 3-month piece of work. It involved some in-depth collection of self-evaluations, of online surveys, of consultations and conversations with staff and professionals and with service users. It also involved the pulling together, of course, of the information and then looking at how we share it, disseminate it, and how we learn from it. The outcome of this piece of work was some very rich knowledge and skills, some affirmation that we did know quite a lot about ourselves very well, but also other areas of work that we might want to focus on. And this piece of work was then handed to one of the subgroups of the board, the exploitation subgroup, with them holding now responsibility for developing a work plan from the findings of that thematic review and making sure that the work is implemented and that learning is embedded, and that we continue to improve practice, share and develop as we go on. I think another piece of area of work that I'd like to raise with you and take questions on if you want is the increased number of referrals that we've seen since we've been working in this new way for child safeguarding practice reviews and for safeguarding adult reviews. And I think we would like as a board very much to stress that we see this actually as a positive move forward, because what it's showing is that there is an increased confidence amongst professionals to recognise issues and circumstances that might point to abuse or neglect across the spectrum of ages and abilities. And I think the willingness of people to put forward referrals for consideration for review is something that we should see in a particularly positive light. What this has enabled us to do is to undertake a number of statutory reviews, which the child safeguarding practice and the SARS are, but also to look at other ways of reviewing the referrals that are coming in and carrying out tabletop reviews or other ways of learning. The other thing that we've done that I think has been particularly helpful and well supported by professionals across the county has been the development of 7-minute briefings and lessons learned briefings. So every time we undertake a review, we follow this up with a briefing, a short briefing on a piece of A4 that picks out a particular area of learning that we would like to spread the word about and make very simple and very easy for professionals to pick up and link to the reviews that we've done. Equally, the lessons learned briefings are again a short piece of probably no more than 2 sides of A4 that summarise the review that we've undertaken and share and highlight the lessons learned, what professionals can do to with the information that we've got, and what indeed the public can do, because these reviews are published on our website. The numbers of reviews are in the annual report for you to see, and we received 21 during this period, 11 of which were adults, 10 of which were children, and of those 21 we carried out 14 rapid reviews. These rapid reviews are a very quick piece of work where we collect information from everyone who may have been involved or know the child or adult, and we have a very quick look at that information and decide if it meets the very clear criteria to undertake a full in-depth review. And the numbers of referrals during this period that progressed to a full review were 4, and that included our first adult case, 2 children's cases, and 1 that was a joint child and adult case. I think the other thing to bring to your attention in light of COVID, we've obviously been keeping a close interest in the impact of COVID, and I think there'll be more of that on our next report. But for this year, we have been considering the impact of COVID on every review that we undertake. I think it might be helpful. I don't know, Gemma, you may be interested in seeing a little bit of a summary of what we have come up with, because it's certainly clear that COVID has had an impact and had effect on things like the timeliness and the ability for people to attend appointments in some areas, particularly for some of our children's cases, the ability to actually see a child on their own. And we have picked up more and more areas of concern with mental health. And I think for yourself as a health and wellbeing board, one of the recommendations that we have got in our report is that we look with some care at commissioning intentions in the coming year around the impact of COVID on mental health in particular. But again, I know you've picked that up in the work that you're doing. Very happy to expand on anything that's in the report that I haven't fed back to you verbally on, but I think those are the 2 main areas that we focused on this year: the development of the new ways of working, the exploitation, and the learning from the case reviews that we're undertaking.
Thank you, Lynn.
Okay.
Any questions? Yeah, I have a hand up. JF, who's JF? Because they're not on my screen.
It's me, Les. It's Judy.
Yes, carry on, Judy. Thank you.
I just wanted to make a comment about the 7-minute briefings. I think they're a brilliant idea. We're all really busy people, and getting to read things or do training is very difficult. So I really like that 7-minute, very short, sharp briefings or training. I'd like to know more. So if they're on, I think you said they're online.
They are, yes, they're all available online, and there's really quite a big selection now. I'm having a look to see, what we've got. I think in the period of this, we've done things like the JTIs, rapid reviews, children moving across local authorities has been an issue. The role of special guardians, a whole host of things that have come out of the reviews that we've done that warrant a little bit of concise and precise learning. Thank you very much. I'm glad you like them. I'll pass it back.
And as we are doing, it's very quick. Have you got any quick links to it? Save us having to search for it.
It should be on the. It should be on our. Rita, it'll be on the.
Yes.
Can you tell me where the link is? It's on the the annual report. The link, I think, isn't it? But.
Yes, what I can do is at the end of the meeting is send the links through
that'll be good.
To Gemma, send out to everybody.
Thank you. I've got Jeff Morgan, Marion Humphreys and Russell Hardy. Jeff.
Hi Les, thanks very much. Jeff Morgan, portfolio holder, Children's Services with Warwickshire. I'd just like to welcome the report, which I think is a very good quality piece of work. I don't propose to say anything much about the detailed content. That's for others to get into. I have had a word with Amrita about a couple of small points, but I think this is a very good piece of work, and it shows that we're capable of keeping high standards when the system itself is changing. I also welcome the focus on exploitation for children and adults, and sadly that's something which is a live issue in Warwickshire. But thanks to Elaine and Amrita again, and I commend the report to the board. Thank you, Les.
Thank you, Jeff. Yes, I would echo those sentiments with my adult rather than health hat on. Thank you for that, Jeff. Marion Humphreys and then Russell Hardy.
Hi, my question was, when all the children have gone back to school now, would this information about your safeguarding service be of use to actually start discussing this with the schools now, so as they actually know what service you provide?
Yes, we have got an education subgroup which is part of the board, and schools are very much part of, they attend our partnership meetings and are very heavily involved. We're involved equally with the work that comes out of schools around early help, because that's for us another area of interest from a safeguarding point of view. Schools complete an annual audit themselves, which we use and we have used in our audit work, and they participate in all of the audits that we undertake. I am also going to be attending the Heads Conference a couple of times to just do direct updates with the schools to try and reach them. It is a slightly trickier area of work, reaching all of the schools. But again, I think they have fed back to us that they're very appreciative of the 7-minute briefings. So I think those are reaching them, particularly the ones that relate to children's case reviews. Yeah, there's a lot of work going on to make sure that they are A, integrated, and B, very engaged in understanding the work of the board and taking part in it.
Yeah, I'm just thinking I'm in a very rural area, and you're saying that I'm in a very rural area, and you're saying about difficulty of getting to appointments and things like that. And it's, it's just one of those things. I'm in rural North Warwickshire. So it's just one of the things we've always got problems with is getting our rural residents to any appointments at all. But very good report. Thank you very much indeed.
Yeah, no, that's a very valid point for us to remember. Thank you.
Thank you.
Thank you, Marion. Russell?
Yeah, just quickly, Les, thank you. And just to reinforce what Jeff and Marion have said, Elaine, and everyone involved in the production of the report, very, very helpful. Thank you. I guess my particular anxiety is for children in a COVID lockdown situation, not being able to access or speak up given their home environments. I know we've had exactly the same problem down in Herefordshire with Wye Valley and the young people's team down there. How assured are you, Elaine, that we haven't got some real problems developing?
We've discussed COVID. We've had COVID reports and COVID feedback at executive level and all the way through every time we meet. I think it's always hard with these questions to answer them, because of course you can't be assured of what you don't know about. But we do know that every effort is being made to try predominantly to see the children, if we're talking children here, on their own. But this has become an issue that we know is difficult, and I know the social workers in particular and health visitors are trying to look at ways to resolve that. We have had, probably with some of the reviews that we look at, occasions where we know if we had been able to go in on a one-to-one and see the children on their own, we might have just picked up on something a little bit sooner. But I don't know if Nigel's hand is up because he wants to say something about what he is doing with the social workers to try and overcome this as an issue. It is a real one. And do you want to help out with what you're actually doing through social care, Nigel?
Yeah, if I may just add, I mean, I think there are two different issues. So for children who are known to us, yes, clearly what we have tried to do is put into place as many different ways that we can continue to see them as possible. So every child was risk assessed at the start of the pandemic, and arrangements were put in place. So some had to continue to have face-to-face visits, some had what I might broadly describe as doorstep visits, some had online, communications. We're now back almost to the point, if not actually to the point, where everyone is getting face-to-face visit. So I think we were reasonably confident about what was happening in those families. I think the challenge is those who are not known to us, where incidents happen, they're not in school, so they can't be seen. And schools are our biggest referrers, or schools and the police roughly equally are our biggest referrers. And so I think that is the point of most nervousness. I suppose what I would say is what we've tried to do is to reach out in as many different ways, and we've really focused on our social media offer, ways that people can contact us electronically. We've used communications drafted by young people for young people to kind of flag those up. So I think we've done everything that we can to kind of give people the opportunity. But of course, we will never reach everybody. So there is an expectation, I think, that there's what is often described as kind of pent-up demand in the system. We just don't yet know the extent of that.
Okay, thank you for that. Also, I mean, in Warwickshire, we are seeing some increase in domestic abuse, but that will be where that flows in the future. But certainly that is part of the release we're talking about with children and getting people we need to see confident enough or them enabled to get to be alone to actually talk to us. So that is an issue. Are there any other queries for Elaine? In which case, Elaine, can I thank you really very, very much on our behalf for the work you've done, supported by Amrita, who has done a sterling job. As someone who's done children's safeguarding and now adults, I think the situation we have now with one board under your chairmanship is absolutely where we need to be, and it's working very well. So thank you and your team very much.
Okay. Can I thank you for your kind words, but also, I mean, the work of the team is phenomenal. So Amrita, thank you very much. I know you've done such a lot to help us get into this place this year. Thank you.
Thank you very much. So if we could acknowledge that report and what's in and what's been said, and move on to item 5, which is our Health Watch annual report. And can I ask Liz Hancock and Chris Baines to take the floor? Who's kicking off? I don't know.
Well, I think I'm starting. I don't know whether we're doing the presentation, Chris.
Yes, we are.
Whilst I wait for the pretty pictures to come up, which is obviously more attractive than looking at either Chris or I, thank you for once again enabling us to present Health Watch Warwickshire's annual report 2019 to 20. If we could move on to the next slide, please. So the agenda, I'm talking on the first 2 items, and then Chris will be taking over from COVID-19 and discussing the survey highlights from there. So if I could just click onto the next screen. So a lot of information in this screen. Obviously, the year covers from the 1st of April 2019 to the 31st of March 2020, so quite an experienced, different start to the end of the year as for a number of people. So 2,115 pieces of feedback from the public. That's an amazing number. It includes 234 inquiries and feedback about services, and the remainder of the comments that we've received on the number of surveys we've done throughout the year. Nearly 1,900 advice and information inquiries. During the year, 197 people were signpost onwards, and there were nearly 1,700 views on our website's advice and information pages. So it shows that the diversity of our approach is either face-to-face telephone calls or through our website. We've noticed a 50% increase in online activity, with nearly 6,000 visits to our website throughout the year, plus a further 5,000 on social media and 2,000 engagements at community events, when obviously we used to be able to see people face-to-face. We've had 6 reports published throughout the year, 3 enter in view and 3 on different projects that we've managed throughout the year. 2 standing conferences on patient voice, and as it indicates, a survey on the PPG awareness, digital portal engagement and the long-term plan survey. And this clearly highlights the quantity of work achieved, and as you can all imagine, the potential impact made. It sounds great, but what does it actually mean to the people of Warwickshire? It means that Healthwatch Warwickshire is able to act as an effective method for local people, ensuring that their voice is heard where it's needed to be by decision makers like yourselves with primary and secondary care settings, and that their voice helps to shape future services and developments. Next slide, please. It's a whistle-stop tour, by the way.
Yes, thanks, Liz.
So, as with a number of people, we've had to change the way that we work, because none of us could have envisaged that 2020 would bring about the challenges that we've all had to face. So, like many, Healthwatch Warwickshire, following guidance, had to adapt their ways of working to help ensure the safety of the public, staff and volunteers by stopping all face-to-face work. The offices closed on the 24th of March and staff began working from home, which meant ensuring that they obviously had all the necessary IT equipment, telecommunications, and most importantly, safe working practices and wellbeing support. The team also worked hard to make sure that local people continued to have a way of expressing concerns or seeking support and advice when they needed it. We looked at doing virtual board meetings, because as we quickly realised we'd need to find another way to engage with the board, as well as ensuring we continued to meet as required. Virtual meetings, I think, as many of you have found, have proved to be a very effective and efficient way to conduct business, particularly board meetings. Particularly for myself, as obviously my normal base is in Nuneaton at the Mary Ann Evans Hospice, and Healthwatch base is normally in Leamington, so it saves a lot of travelling time, which is very efficient. We've also recently decided to hold informal catch-up board meetings every other month to ensure that the smaller, sometimes more important discussions can actually continue to take place outside of the formal board setting. Telephone service to the public was restored within 4 days, and websites that are shown there were resumed within 5 days. It's important that we were obviously able to continue to ensure that the people of Warwickshire were able to access Healthwatch Warwickshire and the information they required when they needed it. Connectivity to the wider audience obviously did take a little bit longer, but I think the fact that we achieved that in under a week was very positive. Daily update bulletins became an important part of ensuring accurate information was available for all. An engagement strategy with all key partners has been implemented, and Healthwatch Warwickshire's lockdown task group continues to explore how services can effectively be delivered in the future, including face-to-face activities like public engagement and outreach. Ways of conducting these on a virtual basis may be required for the interim, and we're constantly staying up to date with CQC and other organisations regarding guidelines for the possibility of reintroducing our Enter and View programme. But obviously, currently, as many of you will be aware, there's no definite plans on when this is going to be possible. As the situation we all find ourselves in is constantly evolving, so the team also has to evolve, seeking new ways of working and new ways to engage. And to quote from my message in the annual report, before I hand over to Chris, I'd like to end by saying, with the ever-changing health and social care landscape and the continuing uncertainty, I'm very proud of our small team of staff and volunteers who work hard to encourage and engage with local people to help local services to meet their needs. It is now more than ever a complex world that we're working on, but I've noticed that the team never lose focus of the end result, and that's making care better for people. I'm now going to hand over to Chris, who will highlight some of the surveys and the projects that we have launched throughout the year. Thank you.
Right, thanks, Liz. Can we have the next slide, please? One of the first things we did, building on the levels of activity that Liz has already described, was to send out in May and June a survey about people's experiences and feelings about COVID-19. The survey went out across Coventry and Warwickshire, and we had 1,100 responses in the 4.5 weeks the survey was running, and about 800 of those came from Warwickshire. And there were some interesting details about those. The majority of people who responded were of working age, and that would not be normal for a Health Watch survey. We would normally not get that. Well, we had that this time. I think what we're doing is looking at why that happened. 108 people said they had had support for COVID-19 symptoms. So 1 in 10 respondents had been treated for COVID. But the next one is really quite, is one that I think made a bigger impression on us than any other, is that 839 of the 1,100 talked about the impact on their mental health and the problems that had arisen from that. A lot of it about anxiety-related conditions. 27% found it difficult to get clear information. I think that has now changed. As we've gone on, we've got better at communicating and giving clear information, so I think that has now changed. But back in June, that was the position. And the last one was fascinating. 6.5% had changed gender identification since birth. And what we think that means is that people are now more confident about talking about these issues, whereas they might not have been previously. I certainly hope that's the reason for it. But it was an interesting development, and it's one I think that will continue to develop as we go along. Have the next slide, please. So these are what people have been talking to us about, not just during the COVID-19 survey, but also in phone calls and in emails since then. And I guess none of them are particular surprises to anyone. There are people concerned about the postponement of non-COVID services, and in particular around screening and immunisation services. Those are the ones that people seem to be concerned about, and a lack of clarity about where those services are continuing. And we have been pushing the message about using the NHS for business as usual for some time now, and hopefully that's beginning to have an impact. There are a lot of concerns about testing, how to access it, how reliable it was, what the weights were, although those do seem to be easing off now, so I assume the position is getting better now. And also some clarity about who needs to shield and who doesn't, and how you got on a shielded list. And again, I've noticed that is beginning to ease off. The concerns about impacts on mental health I've talked about already, and a lot of concern about people feeling isolated, particularly where they were living with people who had behavioural challenges or addiction or related conditions. So a lot of concerns about people feeling isolated, and we're particularly worried about carers at that point. A lot of anxieties relating to care homes, but in fact the position on care homes in Warwickshire was actually pretty good all round, and certainly better than most places we've seen. And there were concerns about this, the use of telephone consultations, particularly with GPs, in the place of face-to-face. The national survey indicates that 2/3 of people prefer the telephone to face-to-face because they don't have the travel, and they don't have the wait. So I think that is, again, beginning to evolve. And I'm really looking forward to the Warwickshire County Council's survey on COVID to see how people's attitudes have changed since we did all this work. So looking forward, if I can go on to the next slide, please, which is the last slide. Looking forward now, we don't know what the outlook is going to be post-COVID, indeed when we're going to reach post-COVID. But we will need new models of both engaging with the public and our enter and view service. And we're exploring those and talking with the CQC and other local health watch to see how those things are going to be delivered in the future. We are training our staff on both infection control and the use of PPE in anticipation of increases in activity, but at the moment we're still waiting for guidance from Healthwatch England. We will need to pick up on the mental health challenges that people have been describing to us, and we will have to respond to that in some way. We're not quite sure what that will look like yet, but it was clearly a major issue. Our Rights Access project, which was about homeless people, we're now going into the COVID phase of the Rights Access project to see how the experiences of homeless people have changed since COVID began. So we're doing that particular piece of work at the moment, and we will then extend it to people who are deafened. So looking forward, we're going to have a series of projects about patient voice, and in particular how the patient voice will be heard at all levels of integrated care systems, both from system, place, PCN and local level. We're going to see how we can make that work. We're doing a lot of work on discharge pathways at the moment, and we just completed a survey on the discharge process, and we're now looking at one on the blue beds pathways. Digital care is going to continue to be a problem, and Healthwatch England this week is going to be launching a project about digital exclusion, and we'll be taking part in that just to see how much of a problem it is. And the final one, I think the future of patient groups post-COVID is one that needs to be considered because the traditional ways of working, getting together and meeting, are no longer available. So we'll need to look at the future of patient groups and see how that will develop in the future. So that's our report, Chair.
Thank you, Liz. Thank you, Chris. Any questions of anyone? Judith? Judy?
Yeah, sorry, I'm in this. I'm particularly interested in what you said about the rights access projects.
Yeah.
Will you be working with the hostels that have been, William Walsgrave in Leamington, and I think there's one in Stratford as well, isn't it? Where a lot of the homeless people have been residing before they're hopefully given the opportunity to have their own places or back with families. So, are you working on the street, or are you working with the homeless hostels, or a bit of both?
Yeah, thanks, Councillor. Yes, the Rights Access project was a joint project with those partners. So we've already been working with the hostels and with others, and they've helped us to deliver the original project. And we've now gone back to them and saying, how is the experience of homeless people changing as a consequence, both of the housing that was there for a while and what it is now. And we'll be working with them to see how the Rights Access project concludes. Will need to be amended to reflect current experience.
I think COVID was one of the successes of COVID.
Yeah.
That for the first time, the homeless people were really put to the forefront and worked with individually, and it wasn't easy. There was a few who didn't want to any change in their lifestyle, but the majority did, and I think if COVID has taught us anything, it's taught us we need to look after our homeless people. So good project.
Yeah, thank you. I think
I'm hoping the feedback from the people we're working with will reflect some of that.
Yeah. One thing that has been a success in partnership is the Warwickshire homelessness project crosses all, and that's good, and we should keep it up. So Chris Ham.
Yes, well, first of all, thanks to Liz and Chris for their very helpful and informative report. Specifically, I wanted to pick up what Chris said about patient voice and how that is heard within we hope in the future, the integrated care system. I think Chris and Liz will know we've been doing a bit of work on this through Fiona Langworthy from Swift, and now we've asked Nigel Minns to take a lead on this across the Health and Care Partnership, soon to be integrated care system. I'm very much wanting to find better ways of hearing and responding to patient voice at all levels. The one thing that comes out very clearly is, as a system, patient voice is particularly important at a neighbourhood, locality level within our 4 places, as well as at the system level. So we're very open to your suggestions and your ideas on how you can help us do that. And as I say, Nigel is kindly put his hand up in another context to take a lead on this for us. Thank you.
Thank you.
Anyone else? I have up on my screen. No, in that case, thank you, Elizabeth, and thanks, Chris. Totally support the way you're going forward, and look forward to working you on, as Sir Chris and Nigel are now saying, how we really get the patient voice into everything, because in my view, we have you there. We don't need to reinvent the wheel.
Thank you, Chair.
Thank you very much. And can you liaise with Gemma on your results and our results so that we pick them in looking at our strategy, Chris?
Yes, Gemma and I are fixing up time to meet, Chair.
Excellent. Thank you very much. If we could move on to item 6, and that is Duncan, our COVID-19 health impact assessment. Duncan.
Yes, thank you, Chair. So I'll give a bit of a background before coming back to the recommendations, and just to inform and assure the Health and Wellbeing Board about this piece of work and how we're moving forward with some of the findings. So this was a rapid piece of work conducted through the JSNA programme and initiated by the JSNA strategic group in response in terms of the relatively early stages of the pandemic, to try and understand what the wider impacts of COVID-19 would be. So obviously we saw the number of infections rising and then sort of peaking and decreasing, but I think it was quite clear that there were going to be sort of some quite major wider social impacts from that. And so this piece of work was to try and develop that shared understanding across the system about what those impacts were. So as I said, it was initiated for the Warwickshire JSNA programme, but actually there was a lot of partnership working, and I feel it was a stronger document because of it. We, on the group that wrote it, we had representation from the CCG, CCGs, as well as Coventry City Council, to ensure that it was a system-wide piece of work. And so I want to give my thanks to those organisations, of course, and to the wider range of organisations who provided data and in order to help give us the biggest picture that we could at the time. In terms of the analysis, we used the King's Fund population health model with the 4 quadrants of wider determinants of health and wellbeing, health behaviours, integrated care system, and the places and communities where we live to structure our analysis. And 2 deep points came out of it, which are worth reiterating at this stage. Firstly, out of all of the indicators that we tracked and looked at about health and wellbeing across Warwickshire and Coventry, it's very few were unaffected at all by COVID-19 and the pandemic. So I think that represents the sort of the breadth of the impact that this has had. And the point that we concluded from that is that there's a key principle about how we work together on recovery and ensure that our plans are connected. Its recovery has to work across all organisations. And the second point is we obviously know and understand the impact that COVID-19 has had on different communities, BAME groups, people living in more deprived areas and different occupations. And we found that from the analysis, it was showing a picture that the wider impacts also fell on the same groups. So again, thinking in terms of the deprivation and the vulnerability that the pandemic has shone a light on, some of the wider impacts also impacts on those groups. So it's a double impact. We developed a range of recommendations which are in the report, and again we're sort of keen to develop them as a system. The cross-cutting nature means that there's things in there and findings which are relevant for different organisations, but hopefully the framing that I've just presented will sort of help to unite some of that effort. However, and we discussed this, and it was presented at the Place Forum as well with some of those findings the last meeting. However, also just to sort of mention to the group, discussions at the cross-system P&P group within the Health and Care Partnership and working have been quite positive around this, and working with Coventry City Council Public Health colleagues, we're keen to sort of describe a set of more specific actions off the back of the recommendations that group can take forward. The other thing to note is that obviously these are sort of our findings based on where we were in the pandemic, and as more data becomes available, our understandings will further develop. So again, we're also looking into how we might be able to provide further iterations or further pieces of analyses to keep everyone up to date with sort of what the recovery is looking like and the wider impacts of COVID, again, to keep that shared understanding. So with that in mind, put this to the Health and Wellbeing Board with a couple of asks. So one is, to note the findings. Secondly, we were keen to publish it as part of our on the Warwickshire County Council website. So I'm asking for the board to endorse that. And finally, the sort of a question for comments is how we can best utilise these findings when engaging in reset and recovery planning across the system.
Thank you, Duncan, for what you describe as a quick piece of work. It is very thorough and immensely useful. So thank you and everyone that's involved in doing that. Any comment or question? I can see no one on my screen. No, so we accept that. And certainly I'm sure we endorse publishing it on the Warwickshire County Council website and any other websites that I'm sure we feel are appropriate within partner organisations. And the other thing is utilise the findings and anything that comes along. Well, certainly at this stage, you could liaise with Gemma about putting anything that's come out of this as we refresh our strategy and make it more COVID-proof, shall we say. That really would be helpful. And has it been to all the 3 place partnerships?
The plan is to take it. So it's been to Rugby, and again we'll pick up. I'll pick up with Gemma and the different place partnerships about how we can best use that to shape the plans.
Thank you, and we look forward to receiving your updates as COVID enters an interesting phase at the moment. Again, does it not? So thank you, Duncan, and your team. Thank you very much. If we could move on to item 7, which is our Black and minority ethnic communities and the effect of COVID, and I think Sade is here to take this one and take us through it. Thank you, Sade. No, is it you, Nadia?
No, it's not actually. No, sorry, I don't know. Can't see Sade on the call at the moment. I'm for the next item, but.
Shall we move on to item 8 and just see if Sade is joining us for this item? Nadia, so we move on to item 8 and welcome Dr. Nadia Inglis on seasonal flu and where we're going with such issues. Nadia, over to you.
Yeah, thank you very much and good afternoon. I don't often get to come and present to the Health and Wellbeing Board, so thank you for having me. I was wanting to really just update the board on some of the work that we're trying to keep ongoing that we think is really important at the same time as continuing the COVID response, and that relates to childhood immunisation uptake and our efforts to increase immunisation uptake. Something similar has been presented to both the Warwickshire North Partnership and South Warwickshire, a South Warwickshire Partnership group, and also the Coventry Health and Wellbeing Board. But I think Rugby's a bit of a gap at the moment, so some members may have seen something like this before. But one of the things that's concerning us both locally and nationally is that we have seen reductions in uptake of the key childhood immunisations, and it's been drifting down over the last sort of year or year and a half. And for us, the biggest concern really in terms of lowest uptake is in the what we call preschool immunisation. So it's the second dose of MMR and the 4-in-1 booster dose we seem to have particularly low uptake of. So in the paper that you have in front of you, you'll see that the uptake of 2 doses of MMR at 5 years for Coventry Rugby CCG for Q3 1920 was 78.3%. For Warwickshire North, 83.7%, and South Warwickshire, 88.8%. One thing I would say is, though, that the first dose uptake is quite a bit higher, and that obviously provides protection for up to 90% of children, but really we want to see the kind of 95% uptake really to really achieve herd immunity. So for 1 dose of MMR, we've got 93.2% uptake for Coventry Rugby CCG, 96.3% for Warwickshire North, and 96.6% for South Warwickshire. So I did just want to temper that bad news story with actually, you know, the first dose uptake is quite good. So there seems to be something around this preschool uptake that has been a problem for us. In terms of what we're doing about it, currently there's some work being led by one of my Coventry colleagues, working with strongly with CCG colleagues, particularly primary care commissioning colleagues, to firstly look at the data, because things have changed quite significantly, particularly for Coventry. We wanted to make sure the data was robust, and we've shown that we do think that the cover data, unfortunately, is robust, because it's giving us a story that we certainly haven't seen previously in Coventry in particular, but also we've got lower uptake in Warwickshire now as well. A big database has been put together, so we've got uptake by GP practice that primary care commissioners are now using when talking to GP practices in their quality meetings to talk through what some of the barriers they feel have been in terms of being able to improve uptake, because we know nationally from surveys that have been done that the biggest barrier is actually access, and not necessarily because parents don't want to get their kids immunised, or they have objections to immunisations. But on that point as well, we were keen to do some public facing and stakeholder consultation on that to understand what our local barriers were, but we had actually put that element of the work on hold. But we ran a short, I say we is the royal we, because it was actually Becky and Paula's team who led on this, the children's team, an immunisation campaign in July, and we want to run a much bigger one, sort of at the right time as we move forward, really to really try and get some movement on the uptake figures that we're seeing now. So. There are also about 40% of GP practices across Warwickshire that have signed up to an enhanced national MMR vaccination schedule, so that they get paid for essentially doing a catch-up campaign. And we're also encouraging all GP, I mean, these are quite technical things, but GP practices to sign up to data auto extraction to make sure that we've got, you know, accurate uptake data as well. So there's the campaign work. We want to do some public and stakeholder consultation on this, and working closely with those practices where we know we have lower uptake, I think, is really critical, because there's a big variation in uptake between GP practices. So that's the work that's ongoing. Very happy to take questions on that. In terms of flu, again, CCG is a leading steering group on flu vaccination this year, and that's going to become a flu and COVID vaccination steering group. And as colleagues will know, there's an expanded range of risk groups this year. So later in the season, in addition to 65 and overs, under 65s at risk, pregnant women, carers, and the usual children's groups, there will be an addition of people aged 50 to 64 years, and this year also household members of people who are shielding have been added, and year 7 have also been added to the schools programme. So previously it was all those aged 2 and 3 and reception in years 1 to 6. Year 7 are being added, so it's the first time we're going into senior schools this year. So it's a big programme, as I'm sure many members of the board are aware, and there's a lot of work going into what that will look like and how it can be delivered in a COVID secure fashion this year. So there was a little bit of detail in the paper as well about uptake last year across the 3 CCGs, with South Warwickshire usually appearing as having the highest uptake. But actually, we still have, particularly in those clinical risk groups and in pregnant women and children aged 2 and 3, we still have lower uptake than we'd want. So we're really going for quite a lot higher uptake for this year. We think there will be demand, increased demand for it, given that we're given where we are in the pandemic and people wanting to kind of reduce their risk overall from communicable disease over the winter period. So there's a lot of work going into that. So really the recommendation of the board really is to note this work and really to provide, which I know many members are, ongoing sort of support for some of the work that we're doing here, so that we can bring our uptake figures back back to levels that we'd like to see them at, essentially. So, thank you.
Thank you. Now, just one question: that obviously a considerable amount of increased activity this year. Have we enough people in the timescale to get it in time to be effective?
It's interesting for the seasonal flu vaccination campaign.
Looking at flu in particular, yeah.
I'm sure there'll be many different answers that I could give to that one. I think all I can say is I think that actually all the planning that's going into it, there's a huge amount more planning. There's a huge amount of I think senior level input from NHS partners as well, to try and make it as successful as we can. And so I think that's probably all I could say on that. Yeah.
Thanks for that. Marion, you have a question. And then Dave Spraggett. Marion?
Yeah, sorry, didn't want to unplug me again. Nadia, fantastic report and a lot of hard work. I know it is. So well done to your team and you. Cross-boundary is always my bugbear for GPs. Yes. And that goes on. I phoned up the cross-boundary GPs the other day to be told, do not phone for flu vaccines. You will be told when you are able to come. People at high risk will be told first of all. And you just think, well, not even a nice message on the phone. Do not phone was the first message. And all the children in school are cross-boundary. They will get all their immunisations in school, I take it. Because their GPs won't be in. So you'll be paying Warwickshire.
Yes, so for the schools programme, certainly we've got a school-based I've got school-based immunisation services that is commissioned by NHS England. It's Coventry Warwickshire Partnership Trust deliver that for all schools in Coventry, Warwickshire, Herefordshire and Worcestershire. And so they will be doing the children in school, the flu programme, and they're also responsible for other vaccinations of school-aged children as well. So they should be done in school, really irrespective of who their GP is. Yeah.
It just worries me. Cross-boundary again. We're going to have a divide. But thank you very much. Well done for all your hard work.
Dave Spraggett.
Hi. Yeah, I just wanted to just add to this. The flu campaign, I think the standard flu campaign that the GPs are used to, we've not only got enough vaccine, I think we've got a very good plan together for how we would deliver that. So I've got less concerns about that. My biggest concerns are the 50 to 64 cohort, which effectively is doubling the number of vaccines we have to provide. And given the COVID restrictions, which even at best is going to double the amount of time that it takes to give each vaccine, we have got some big logistic problems. And also, I've yet to be reassured by people we will actually get the vaccine that we need on time. And part of the problem is planning these things. You can't just plan on a Monday for something happening on Tuesday, just because we ended up getting 10,000 vaccines appears on Monday evening. So there are some big logistic problems here. And of course, if we add COVID on top, which as we're led to believe is 2 vaccines, that will amplify our number of vaccines we'd have to give by another, quadruple it. So we'd be looking at best part of 6 times our normal vaccines. I know our colleagues in public health are well onto this, and some of it's out of their control completely. I mean, the provision of vaccine Unless Sade's got a secret factory somewhere, she can't actually generate. I can't sort of send her a message and say, can you just send me a few thousand flu vaccines? And the other problem with it, in terms of the flu recall, is of course they're different vaccines for different age groups, and we don't necessarily get the supplies that we need in a timely fashion. So we summon all the over 65s and then discover that what gets delivered is all the stuff for the under 65s. So I think we shouldn't underestimate the logistic nightmare that this is going to provide. I'm sure, well, Sade and Nadia are nodding because they know, but I just wanted to make sure everybody else was aware of it.
Thank you, David. Yeah, appreciate that. Are there any plans to ask retired nurses that are still certificated or whatever to come back to help or anything like that? Because people will also be an issue.
People is the biggest issue, because and of course that's assuming they all remain fit for the whole duration of the winter, and we have to be realistic. A chunk are going to actually get ill, and so yeah, I think there are all sorts of plans that we are flying around about retired people, and indeed some people being upskilled who are perhaps more like healthcare assistants, because of course in practice we use an awful lot of healthcare assistants to provide vaccinations. So I think that is something that is being considered at this moment in time.
That's useful. Thank you, David. I've no more hands up, so thank you, Nadia, and yeah, we note the work and certainly appreciate the work you're doing, and you have a full support, and if you need to come back to us for any support, do ask.
Thank you.
Thank you, Nadia. Thank you very much. Good to see you at the board. Thank you. Could we move back? I see Sade's beat the gremlins, and ask Sade to present item 7, our COVID and Black and minority ethnic report. Thank you, Sade.
Yes, so this is a report that we're asking the board to note a number of recommendations. The first is to note the findings from the Public Health England review, which was published a couple of months ago, when it started to emerge that there appears to be a relationship between COVID and BAME. The first 11 doctors to die from COVID in the UK were all from BAME communities. We're also asking the board to champion improvements in access, experiences and outcomes for all of our commission services that are accessed by our BAME communities, and to endorse using GSNA type place-based type approaches, a review into the relationship between ethnicity and COVID, especially in parts of the county where we know that we have a higher proportion of BAME groups. Warwickshire, as you're probably all aware, is not as diverse as some other parts of the country, but we do have pockets. And indeed, we've been aware, especially as COVID has descended upon us, that there are some specific communities in Nuneaton and Bedworth in the north and in Rugby that will benefit from some more in-depth exploration of this relationship between BAME and COVID. The relationship is quite stark. So Black males are 4.2 times more likely to die from COVID, Black females 4.3 times more likely. Bangladeshi, Pakistani, Indian and mixed ethnicities also had a statistically significant raised risk of death involving COVID. And what's striking is that these associations remained even after adjusting for other socio-demographic characteristics. And the best way to explain this is that whilst there's a link between lower income groups, so lower socioeconomic status, and your risk of contracting COVID and dying from COVID, it is almost inexplainable why the first doctors to die from COVID in the UK were all from BAME backgrounds, because you could argue that doctors are not necessarily at the bottom of the social scale. So there is some complex relationship going on there that still warrants further investigation. But what we know is that the association exists and is how we can understand and mitigate against it. We're still struggling with obtaining data on ethnicity, even as with some of the data we still get in relation to COVID. So we get some line listing data on a daily basis that tells us everybody who's tested positive for COVID. Ethnicity information is embarrassingly sparse. So we still don't get that in the shape or form that we want. The 7 recommendations that we're asking the board to note It includes mandating ethnicity data, and I know that a lot of it is perhaps outside the scope of many organizations that are currently in this room, but it is worth opening up the conversations and starting to discuss how best we can do that, even if just at a local level. There's a recommendation around improving or supporting community participatory research, accelerating development of culturally competent occupational risk assessment tools, developing culturally competent COVID-19 education and prevention campaigns, and targeting culturally competent health promotion and disease prevention programs. The phrase culturally competent comes up quite a bit in the PHE report, and that's because cultural competence goes beyond translating material into different languages. It's really about understanding what people want, what do those communities want, what works for them. And that's what we're asking the board to look into. I think I will stop there now and take any questions.
Thank you, Sade. What sort of timescale, I suppose, have you got on to start the work and get all partners involved, and what timescale to be ready to present to the next stage, which is a better view of Warwickshire, I suppose, is what you're saying, before we then move on to help resolve the issues?
So we've started some work already as part of our community engagement work. We've put aside some money for out of the Test and Trace grant to support community engagements, bespoke and specifically targeted to BAME groups. As part of the recovery work for Warwickshire County Council, there's a specific priority within our recovery plan that is about targeting BAME groups. And we have again started some work to look into how we might potentially build in a project or some sort of short-term service, even if it's just exploratory piece of work, to see whether we can pick one or more of these recommendations put forward by Public Health England and start to develop them. In terms of timescales, I would say perhaps maybe the next 6 months to 1 year, we would hopefully be able to, well, develop something and have a better understanding, because the ultimate aim is to understand what communities there are within Warwickshire County Council that fall into these categories and exactly what they need.
Thank you, Sade. Very useful. Dame Stella, welcome to the meeting. You've got a question.
Hello. Sorry about being late. It's more a supportive comment than a question, I would say. But I just want to say that I think one of the difficulties for everybody here is the distinguishing between what are kind of long-term objectives, some of which there's existing work going on already, either at a public health level or within, say, community development within the local authorities, or with information from either from providers or commissioners, and what are the short, sharp things that need to focus specifically on COVID. And I think clearly there's a wide-ranging objective to focus on health inequalities, and clearly BAME groups are a very big focus within that. But as Sade indicated, it's quite complex because it isn't all about deprivation. And certainly there was a very interesting report produced by the South Asian Health Foundation, which Kiran Patel, the acting Chief Exec / CMO at UHCW, was involved in, which was also looking at some of the cultural issues behind all of this, including, which doesn't only affect BAME groups, but significantly does, things like religious gatherings, you know, cultural issues about large-scale gatherings and all of those kinds of issues. Now, hopefully, some of those issues have been communicated about more, given that we've gone through, if you like, let's call it the first surge. We don't quite know whether there's a second surge or not, but I just think there's some interesting work to be done in distinguishing between what are the long term, what are the short term, what are the things where there's work undergoing already, and what are the things that absolutely do need a kind of short, sharp intervention, let's say between now and December or whatever. And then I'd only add that anything UHCW can do in whatever forum, we're certainly very interested in this area. And Andy Hardy study is on the health inequalities group at the wider Midlands region, and so I know he'll be very interested in this.
I agree with you, Stella. I think what you're describing there is almost like a gaps analysis. What do we have currently? What do we need to put in place? Short, medium, long term? Yes. So I'll take that point on board as well. Thank you.
Thank you.
Chair, I think you've been muted.
Sorry. Thanks, Paul. I also understand there's been some work in Spain. A study trial is going to expand on the effects of vitamin D and BAME community, which might be interesting to find where that is and whether that could be because of skin pigment not picking up that bit of natural protection, which seems to be helping. And there's been one in Spain. I think they're going to do another five cities.
Okay.
She's coming. Thank you. Yeah. Thank you, Shada. Any other questions? No. So thank you for Shada. We certainly fully endorse and support everything, and I hope every partner will give you all the assistance you need and take part.
Thank you.
So thank you very much, Shada. Thank you very much. Good report. So right, can we move on then to item 9, which is Coventry and Warwickshire smoking in pregnancy, for a short presentation, because another one of our main ambitions. So is it Bernie?
Yeah, can you hear me?
Yes, carry on. Thank you, Bernie.
My slides.
You're fine.
Yeah, oh great, good to go, thank you. Well, hello everybody, and thanks very much for inviting me to share the findings of the Coventry and Warwickshire Smoking in Pregnancy Review. So this review was commissioned by the local maternity system board, and it was conducted over a 6-month period. I know I need to move quickly through the presentation, but I'll be happy to pick up any queries at the end as necessary. So now, perhaps a little bit unusually, my first slide is in fact one of the review findings. And I think this helps to illustrate really the sort of terrible burden created through smoking in pregnancy. So this slide shows the difference in stillbirths, preterm births and low birth weight babies according to smoking status. So the green bars, the non-smokers, and the red bars are the smokers. And you can see that for each of these detrimental outcomes, the rate is almost twice as high among the smokers than the non-smokers. And then these outcomes are often tragic, really, in terms of their consequences, but they are also very costly. And for smokers, the cost of delivering antenatal care are much greater. And each year, approximately 55 of the preterm births are actually attributable to smoking. And that small cohort of babies can cost up to £1.6 million for their neonatal intensive care stay alone. And then they go on to need much higher levels of support through their childhood years for education and other support needs, for example. So smoking in pregnancy is clearly a big issue, but not only in terms of mortality and morbidity, but also in terms of potentially avoidable cost. So that makes important context for this review, and further context set out on this slide, but it also includes the anticipated NHS long-term plan investment expected for maternity smoking services in maternity settings. And importantly, the national target to reduce smoking in pregnancy, smoking at time of delivery, to 6%. And this slide shows where our CCGs are in relation to that target. And just look at the yellow line there, which represents Warwickshire North CCG. And you can see that is clearly heading in the wrong direction, counter to the national trend. So moving on to the objectives of the review, again, these are set out here. But in short, through the various processes, we needed to get to a point where we understand the strengths and weaknesses of current provision for smokers, and on this basis, make recommendations for improvement. In terms of the process, we involved a wide range of services, as shown here. We analysed detailed maternity services and smoking services data. We undertook case note reviews, staff surveys, and discussion groups. And I'll now move on and start to share the review findings. So this slide shows smokers at booking by trust over a 3-year period. And you will see the slight decrease at UHCW and Swift, but focusing on the George Eliot hospital population there, less or no decrease. If we look at it by district and borough populations, you will see that there's a range from 9% of smokers at booking in Warwick up to 18% of the bookings from the Nuneaton and Bedworth population. And if we look at it by JSNA, there is wider variability. So from a range from a lower 5% in Kenilworth up to 24% for the Nuneaton, Common and West population. So in addition to looking at these geographies, we also looked at LSOAs where the proportion of women smoking at booking is at 25% or more. So those are shown by the hashed areas here on this graph. So in North Warwickshire, there were 13 smoking hotspots. In South Warwickshire, 4, and in Rugby, 5. I'll now move on to access to look at, here we have the how the smokers and the non-smokers differ. And the red bars are the smokers and the green bars the non-smokers. So you'll see that the smokers tend to be younger, of white ethnicity, they're from more deprived circumstances, and importantly, they have more comorbidities. So their pregnancies are already at higher risk, and this risk is then compounded by smoking. So now to look at access to smoking services. And this slide uses data from across Coventry and Warwickshire, showing average annual referrals to specialist smoking services, and then the proportion that go on to quit. So you can see here the drop off, and just 20% of those referrals overall go on to quit. I think it's important to say at this point that our services, our smoking services, do actually compare well with national averages. This slide shows how, because that was the average, so this slide shows how those engaging with the service and those quitting varies by district and borough. So the green bar represents the proportion engaging with the service, the red bar the proportion set in a quit date, but if we just look at the orange bar, that's the proportion managing to quit. That ranges from just 11% of the smokers from North Warwickshire up to 23% for the population of Stratford upon Avon. Now, I did say, before moving on to this slide, I did say that while our services do compare well, okay, with the England average, we did identify issues with the service model that need to change. For example, there's a delay of perhaps between 11 and 17 days before a pregnant smoker meets a specialist advisor. That's going to impact. Other factors that are likely to influence whether a woman quits or accesses the service or not include how good, sort of how encouraging and motivating the very brief advice from the midwife is. And really importantly, what the smoking culture around the woman is. What messages do her family, friends and wider community give? This will all be really influential, because basically asking pregnant women who are addicted to tobacco to quit is a big ask. And it indicates that part of the solution has to be less women smoking before they get pregnant. And so here, as I say, we're looking at smoking at time of delivery, and this basically just reiterates the slide I showed earlier. And you can see that for the Warwickshire North population, the blue bar, this is national data for 2019-20, and it shows that we're not yet seeing any signs of improvement for the Warwickshire North CCG population. And then this slide, just for interest, shows it by the SATOD by the district and borough population. Just looking in a little more detail at the relationship between smoking status at booking compared to smoking at time of delivery. So in looking at this, in short, we identified that not all smokers had been identified at booking. So some of those will be women who had recently quit but then started again. But looking at this in the whole, we estimated that in total there are approximately 1,550 women who are smoking, and of these 365 are estimated to quit each year. So that puts the sort of low quit number of quit, the 268 through the SIP service, that represents 73% of all of the quitters. So they're making a big contribution. I'll now move on and share what staff told us through the surveys and discussion groups. So in total, we had 580 survey responses and 228 staff engaged in discussion groups. And there's an awful lot of detail in the main report on this, but just the headline messages here. So the vast majority of respondents see smoking as an important issue, but interestingly, not all of them saw it as their job to tackle it. And interestingly, staff do not necessarily feel well trained or confident, particularly midwives, in delivering very brief advice. The listed there are things that staff identified that needed to change, but in the interest of time, I won't speak through them. Just let you look at those. And then a brief look now at compliance with guidance, so basically compliance with NICE standards. And again, this is well documented in the report, but in short, Public Health Guidance 48 about smoking in secondary care settings is not being fully implemented by trusts. Guidance on smoking in pregnancy is largely being adhered to at booking, but less so further along the antenatal pathway. Lots of other detailed findings there, but overall, just to say that SWIFT demonstrated a higher degree of compliance with the standard. But interestingly, it seems from other data that they seem to be better resourced in terms of whole-time equivalent midwives, if you like. So it's good, actually, that this investment is reflected in improved performance. Key question to ask was, well, for the review group, what needs to change? And these are the key changes that were identified by the task and finish group based on the review findings. And again, I'll just let you look at those before moving on to the recommendations. I'll just see what the evidence said. So again, I won't talk through it all because of time, but NICE concluded that interventions for smoking in pregnancy are cost effective and can be cost saving. And, you know, there is other evidence to support smoking in pregnancy interventions, some perhaps controversial, such as financial incentives. But on to the recommendations. So in short, there are three key or overarching recommendations. Firstly, we need comprehensive tobacco control plans. Secondly, a systematic approach within maternity services with improved leadership and training. And I know that our heads of midwifery are keen to implement this recommendation. And then finally, the need for a new model of support that should dovetail with NHS long-term plan investment and provide more immediate access to support and NRT. And just to link back into smoking in general, you can see here we have between 64,000 and 76,000 smokers. And ASH estimates that these cost the local health economy in the region of £120 million. So to an extent, but we may have an unprecedented opportunity to tackle smoking, in that I understand COVID. COVID is driving more quit attempts among the population, which would be a good thing. As I said, the NHS is due to receive investment to tackle smoking, and Warwickshire Council has a good track record in sort of tobacco control that could perhaps be reinvigorated. And all of this would align with what I heard you talk at the beginning of the meeting, securing a better start in life, aligns with population health and population health management approaches. So it would be a good opportunity to see how as a system we might invest, work together, bring about savings and improved outcomes. At that point I'm finished, but I think I ought to ask Sade if she wanted to identify any specific recommendations that she would want this group to receive at this point before I take any questions.
Thank you, Bernie, for a very passionate and heartfelt report. Thank you.
You're welcome, Chair.
Sade's had to restart, so I don't know if she's with us, but I'll start with questions and then we'll see where we go.
No, I can add just a few lines on that. So in the paper, we've made 4 recommendations. One is exactly what Bernie has just stated, is that looking at adopting a tobacco control / smoke-free 2030 programme. The second is looking at an adoption of a place-based system-wide approach that addresses these inequalities that you can see on the screen at the minute. The third is that we're looking at co-production and looking at our current smoking and pregnancy service and commissioning sort of a more integrated model to what we're working at the minute, and that was picked up by Bernie's great work. And then finally, we just need to really look at identifying potential funding sources for a strategic LMNS smoke-free pregnancy lead across the whole system, which a lot of the work that Bernie's, highlighted has been picked up by some of the maternity units on pulling in maternity midwives. But there's something about having a LMNS-wide system-wide approach with a sort of a project lead on that, and at the minute we're looking for potential funding potential funding sources for that, but this is an excellent piece of work funded by the LMNS, and yeah, we're really glad that we've got this asset of evidence that we can put forward in this area.
Thanks, Liam. It is very, very compelling evidence and very well presented, and everybody should be able to read it. I've got 2 questions. Stella and then Marion Humphreys. Stella first. Stella?
Stella, I think you may be muted.
Apologies, everyone. Try again. First of all, to say thank you very much for the presentation, and if the slides could be circulated afterwards, that would be really great.
They will.
Secondly, congratulations to Swift for having made more headway in this area and for having a post in place. I was particularly interested in this because I've asked questions about this back in UHCW before, and I'm very glad to see that the transformation funds are hopefully sorting out a post there and at GEH. Clearly, I can't make a commitment to the funding contribution at this meeting, but I'm very happy to take that point back to UHCW and see if there is any funding that we can find to contribute to that, because I do agree that having a sort of strategic smoke-free lead across the system makes a lot of sense, particularly if at the first gallop it's for 2 to 3 years, to see if we can make a real input that makes an impact and begins to drive the numbers down of women smoking. So I'm supportive of the other recommendations, and I will take back the funding issues to see if there is a contribution that we can make, but obviously I can't make a commitment here, but thank you.
Thank you, Stella. I think one post on a partnership basis is exactly what we need. I'll take Marion Humphreys, then Bernie, you'd probably like to respond.
Okay, thank you.
Marion, and then
Hi,
Sharon.
Bernie. Great presentation. Years back in mental health, I was a smoking cessation officer, if you like, about 10 years ago. When we were I worked in the dementia unit, but I also had to step across for younger mental health if there was somebody pregnant at the time or anybody in distress that was smoking. And it does need a lead wherever you go, because I worked with people who said, look, if someone's in distress, they need a cigarette, they need this, they need that, but you need to sit down and actually talk to the person and have one lead that can give them that time. So if anybody can give them any funding, that is what they need. They need a lead that can actually be the one that can give them time out of the staff regime to actually take this forward. So it would be fantastic if this does go off the ground with the staff lead.
Okay.
Thank you. Sharon Beamish was next, and then we'll come back to Bernie. I'll take all the names, Bernie, then come back to you. So I've got Sharon Beamish and Sally Bragg.
Thank you. Excellent presentation, as everyone else has noted, particularly of interest in Warwickshire North and the impact locally for our population. I understand what Stella's saying, but I do see this is a priority for us locally because it has such an impact. And as you rightly point out, Bernie, it isn't just when these women turn up and they're pregnant. It's well before that in terms of the impact on lives locally, but I'm very supportive and I'll certainly take that message back to the CCG.
Thank you, Sharon. Sally Bragg.
Hello, thank you. Yeah, I've said it before and I'll say it again, but I always have this worry about vaping and the e-cigarettes. They contain nicotine, they have health warnings on the packets, but the report only ever mentions smoking as opposed to including any nicotine or vaping. And I worry about the effects of these big clouds of smoke or vapour on the young children already in the family and the impact it can have on the mothers-to-be. So, yeah, when you have this tobacco control, I know I've been told that the results on vaping and e-cigarettes isn't available and not thought to be as dangerous as smoking, but surely any intake of nicotine isn't good for any mum-to-be. Thank you.
Thank you. Bernie, I'll let you come back.
Okay, well, thanks ever so much, and thank you all for your comments. The point Stella made around the funding and looking for opportunities, I brought this up at the LMS board yesterday because there are transformational monies for LMSs, and I understand that this is actually now, this transformation money might actually be allocated to the 3 trusts. And I did ask the question yesterday at the LMS board whether some of that transformational money from the 3 trusts could be earmarked to be brought together to provide this more coordinated approach. And that wasn't entirely rejected. I think it was, it was there as a suggestion. So that might be something to follow up on. And so I think that picks up with Marion and Sharon's points as well. And Sally, I know I've heard, I know Sally's views and concern about e-cigarettes. And I think the only point I'd make here is that, yes, e-cigarettes contain nicotine, and there is evidence that nicotine isn't particularly good in pregnancy, but the real harm of the cigarettes comes from the carbon monoxide, not the nicotine. And it's the fact that e-cigarettes do not contain the carbon monoxide which really will make them a safer alternative. And as you will be aware, of the public health guidance on e-cigarettes as opposed to smoking, they are an opportunity for harm reduction. They do not take away all harm, and I think they need to be seen as a temporary move towards complete cessation and complete reduction in dependency on nicotine.
Thank you, Bernie. Any other comment, because we need to move on? We're heading for 2 hours.
No, it's Julie. Can I just make a quick comment?
Yep.
I used to do smoking cessation as well in children's centres, and I found I argued not only for the health benefits but the financial benefits, and we did a targeted approach both ways, because to give them more income to buy things for their hopefully baby when they planned one, and just to be able to buy healthier foods because they've got more money, because smoking costs a lot of money. So I think it's a win-win all round, because obviously it helps our lovely babies come be born a lot healthier, but also the family benefits, because there's more money going into the family. So it always worked well with me using both. So I know we don't talk about not giving incentive, financial incentive to pack in smoking, but I think the finance does help as well. Cigarettes are very expensive to buy.
Thank you, Judith. Exactly right. Quick response, Bernie.
Well, I agree entirely, and I think that this is one of the, the things that, in terms of working with pregnant women, is a really important thing to be focusing to actually, the critical issue is building the motivation to quit. And if you're going to have more money, disposable income, and be able to buy nicer things for your baby, it is a great incentive. So I'd agree with everything that's been said there.
Thank you, Bernie. So I've got no more speakers. Thank you all very much. Can we approve the 4 recommendations and ensure that we as a Health and Wellbeing Board monitor and keep it moving forward? Are we all agreed? Yeah, nobody's telling me no. So thank you very much, Bernie. Thank you.
Thank you. Thank you all for your time.
Can we move?
Just take your screen down, please.
Oh, of course. I'll stop presenting.
Thank you, Bernie.
Is it gone?
No. That's it. Thank you. Can we move on to item 10 and be aware of the time? Duncan, the next steps on the JSNA.
Yes, thank you, Chair. So I'll keep it brief as an update of the JSNA programme and what's happened over this year. I mean, I've presented on the health impact assessment, which was one of the outputs, and of course members of the board will be aware the place-based JSNA programme, which was initiated several years ago, was due to finish in March of this year. The delivery was delayed because of the pandemic and the response to that. But pleased to say that all of the profiles have now been completed and signed off by the steering groups. Most of them are on the website. A few are just going through the final stages of editing and approving them with various sponsors. But then that gives the ability to look in depth at place at those 20 to 30,000 people geography. In terms of the rest of the progress, the pandemic has obviously had an impact on our business intelligence capacity in terms of the amount of time that we're now the business intelligence team are doing to sort of produce tools such as the sort of daily dashboard and to sort of get on top of all of the new information that we're receiving to support the test and trace response. However, I have presented what I'd anticipate is the rest of the work programme for the year and a bit beyond within the paper. We're keen to look at how to support some of the thematic work that's going on across the council area, and in particular trialling that approach around mental health. We sort of recognised obviously as one of the priorities in the health and wellbeing strategy that we're consulting on, and as well the various commissioning intentions at both council and CCG side. It felt like a good opportunity to trial that approach with a working group and to learn from some of how we've been managing the development of the profiles, the place-based profiles, and to transport some of that into thematic working. It's not this doesn't mean stepping back from the place-based focus, and within those that thematic analysis, we'd want to draw out differences between the JSNA areas, but with a specific sort of more focused discussion around, for example, mental health or whatever that analysis is on. The other items of work to mention, firstly, around an evaluation about how the place-based profiles are being used and sort of how we might best translate them into usable data and sort of translate them into outputs or sort of reports or similar that might support decision making. Looking at a dissemination plan, which includes sort of how we use some of those tools and how we best use the JSNA data in communications, for example. And then finally, the other thing to just note is that we're having a couple of trainees who are working on particular smaller sort of JSNA needs assessments. Some of that we'd want to sort of bring into and incorporate into part of our programme. The last point, recognising on the health impact assessment that we got quite far and quite quickly through collaboration between organisations. Again, I was keen to sort of use some of that learning and explore and understand where we might best collaborate on some of the thematic work as well. So again, when establishing the steering groups, we'd look at sort of who else we can incorporate, both in terms of to give the strategic steer for the pieces of work, but also to give an analytical steer so that we're making the best use of data. The only other thing just on the thematic work is we'd want to, recognising it as sort of producing a JSNA profile is obviously a sort of a commitment. So we're obviously wanting to make sure that we pick the most impactful pieces of work. So we were looking to carry out a prioritisation exercise working with members of the JSNA strategic group and other partners to understand what would be most of value to the health and care system locally. So if there are a couple of recommendations to note, which I put to the board for comment or endorsement around noting the progress made, using the understanding how we can best use the JSNA evidence base, and to get your comments or endorsements on the proposals for developing a future work programme.
Thank you. Now, just saying, Duncan, one point on Appendix 1, the core membership of the evaluation group, if they're working in quite tight areas, which is the table shows, would it be beneficial to have the local member involved?
Yes, agree. I think that was one of the valuable sort of reflections from the place-based profiles, and it's sort of thank you for drawing attention to its submission there.
Okay, thank you very much. Any queries for Duncan? In which case, thank you for the work on this, because I know it's been a lot, and to look on 1/9, you've 140 analysts working on this across the piece. It shows how complex it is and the amount of work we are doing. So thank everybody very much. And can we fully endorse the recommendations laid out? Yeah, no dissension. Carry on, Duncan. Thanks very much.
Thank you.
And next on item 11, the pharmaceutical needs assessment again is you. Just update us to where we are.
And this is a brief update. So it's one of the statutory functions to produce a pharmaceutical needs assessment. The last one was due to start or the update was due to start in March of this year. The pandemic has, of course, pushed that timescale further ahead, and NHS England have sort of set out that we can delay that process, or areas can delay that process for a year. So the new anticipated start time would be in March of next year. The only other question of the board was, again, we were wanting to align and ensure that we're doing this in collaboration with Coventry City Council. And again, by doing that, hopefully it will give the same, whether it's sort of one output or two outputs. I think we need to clarify with NHSE in terms of what their expectations are and what local systems need to produce. But hopefully by taking a standardised approach, the data and the analysis will be comparable across the whole footprint.
Thank you, Duncan. Fully support that, because even if we end up with two, there's a lot of cross-border issues in citing of the pharmacies and everything else. So yeah, fully endorse where you're at, and I think we all agreed with that, are we? No dissension, Duncan. So yeah, once again, thank you very much, and that should lead us the way forward. So if we could then move on to our updates, and the first one is the Better Together programme update. Rachel.
I don't think Rachel's here, so I'll quickly talk to this. Les.
Oh, thank you, Becky.
So this is an update, as the board will know that they get fairly regularly, around the Warwickshire Cares Better Together programme. I'm not going to kind of dwell too much on what is in the report. Obviously, if people have got any questions, I guess the first point to note is that we were expecting the updated guidance end of August, beginning of September. We're still awaiting that. The report does outline how we have continued to deliver the projects and programmes as part of Warwickshire Cares Better Together to support our COVID response. And obviously, if anybody's got any questions about that, happy to take those. You'll also see an update on the 4 key performance measures linked to the Better Together programme. Just a note that delayed transfers of care, which has been a priority for us for some time, is currently suspended, with the expectation that that is likely to remain suspended or be removed as we move forward. You've also got an update on the 3 other areas of performance, all of which you will see have been impacted in the first quarter by the COVID pandemic. When you look at electives, also reablement, which has continued to perform well, and then admissions into residential and nursing homes. So hopefully it's fairly self-explanatory, but happy to take any questions, and it is here as part of the regular updates to Health and Wellbeing Board.
Thank you, Becky. Very, very, very good results, and we'll certainly know on transfers of care. We've really worked as a system and really improved that. So yeah, well done to everybody, and thank you for it. Any questions for Becky? I can see hands and not names. So whoever you are, carry on.
I think it's me, Les. Apologies, you can't see my name. Becky.
Hi, Russell.
It's Russell. We've done a great job as a system in this, but just coming back on what you said about the uncertainty about the funding at the end of September, what's your sense of the degree of risk we face if we don't hear something in the next couple of weeks about going backwards in our work, particularly with care homes and domiciliary care providers?
Yeah, I think in terms of the current programme, Russell, we're not expecting that we will get anything that kind of says it's stopping. And there is a recognition that obviously the resource that we have to deliver the programme is absolutely fundamental to the things that we're delivering locally. It's just that we haven't got any of the kind of updated specific guidance for this year that we would usually have had by now. But at this point, we're of the view that we will continue to be able to deliver the programmes. There will still be a way for us to do that in light of what is published, and that there will be appropriate resourcing for that. Obviously, aside from that, there are the wider issues around what the financial support for the care sector will be, and that obviously remains an area that we're keeping some focus on and looking at our planning around how we might manage what that looks like. But in terms of the Warwickshire Cares Better Together programming and the Section 75s and the resources that we've got, we expect that should continue.
Thank you, Becky. Happy with that, Russell? Thank you. Any other comment? In which case, Becky, thank you very much.
Thank you, Chair.
Good to see you. And we can move on to item 13, which is Place Forum update. Sir Chris. Sir Chris, is he still in the room?
All right.
Yes, he is.
There we are. Yes, so many of the issues we discussed on the 15th of July at the Place Forum, a joint meeting with the Health and Care Partnership Board, we've actually covered on today's agenda and in fact updated on those items. So I won't repeat what has already been said on the impact of COVID-19 on our communities, the impact on BAME communities and so on. Can I just make perhaps 3 brief points? Given where we are in our agenda and the meeting. I mean, first is to recognise the fantastic work that's been done by all of our health and care services over the last 6 months or so, particularly around the first wave. and rising to the many challenges that presented. And we've seen some great examples both of innovation in how our services are delivered. And I think Russell may have referred to the LGA document on discharge to assess in Warwickshire as one example of that, and there are many others besides. So a huge amount of innovation, but also a great commitment, I believe, to collaboration between our councils and the NHS, between our different hospitals, especially in relation to intensive care, and making sure there was support for each other in dealing with the demand back in March and April. So wanted to recognise that, Chair, rather than just assume we all understood it. The second thing I wanted to say is at the Place Forum, we had a discussion of the Test and Trace programme. And Sade and yourself have been very closely involved in the Beacon project, which brings together Coventry, Solihull and Warwickshire, collaborating as one of 11 areas of the country in England to put in place the right arrangements for test and trace. My involvement suggests we've done very well in that programme, but I think the big challenges are yet to come. We're seeing those in Solihull because of rising case rates. We're seeing it nationally with the difficulties many people are now having in accessing tests locally and getting the results back very quickly. And that's a major concern, obviously, given we're going into autumn and winter, and we would expect a continuing rise in positive cases and growing demand on the test and trace programme. So I believe Matt Hancock said this afternoon in the House of Commons, it will be a matter of weeks before the problems around the laboratories and the lack of accessible testing resolve. Well, that's a very imprecise assessment of the position. Let's hope it's 1 or 2 weeks rather than 5 or 6 weeks. So we can't afford that sort of delay. And the third and last point I wanted to make was more around what's happening now in reinstating or giving more priority to the non-COVID services, particularly in the NHS. There are other colleagues in this meeting who can speak to this in more detail than I can. But this is now receiving quite properly huge amounts of attention. Cancer services are one example of that, where we are making progress. Reducing the growing backlog of people waiting to access diagnostic tests or indeed to have their surgical procedures. That is equally receiving a lot of attention. Mental health is a high priority for reasons we alluded to earlier on. There are two challenges, I think, in doing what we all want to do. One is public confidence in the NHS. We know that many people, understandably, have been reluctant to come forward and seek access to NHS services. The good news is, if you look at the trends, people are becoming more confident, and some of that reluctance is hopefully a thing of the past rather than of today. The second challenge is the proper measures that every part of the NHS is putting in place to provide services safely, especially on infection prevention and control. And that will act as a brake on how quickly we can get all of our services up and running, whether it's in the community or in our hospital. So I know everybody across Coventry and Warwickshire is working incredibly hard to reinstate and expand the non-COVID services, and we can see real progress in some areas. But this is going to be a huge priority for all of us in the NHS and through the Health and Care Partnership. And the last thing I'd say is very much with this continuing commitment to mutual aid, working together. You know, we're stronger when we work together than when we work separately. And I know Stella and Russell and other colleagues would want to endorse that, but I don't want to underestimate the scale of the challenges we face as we embark on this next phase. Thank you.
Thanks, Chris, and totally endorse your remarks. I suppose something we would say is any influence you have to actually getting the message through the government that actually, if they gave us more control of test and trace and the funding, we could actually make it work.
I agree, and I think several of us have been trying to make that point with only a little bit of success.
Thank you. And any comment from anyone else on this item? No. Dame Stella.
Sorry, Leigh, after you.
Yeah,
Oh.
Russell and then Dame Stella.
Russell, by all means, go first.
I was just going to say, just to reinforce what Chris has said, that I'm sure, well, I know UHCW are in the same position as Swift and George Eliot of putting our foot to the pedal in terms of elective work, cancer work, and just getting the acute sector back up and running as we want it to. But just for colleagues on the call, the challenges of that are very real, given the COVID protocols that we have had to put in place, which has affected productivity of our theatres. It's affected the capacity of our beds. It's also affected the flow and the anxiety, particularly amongst older patients, about accessing NHS services. So all of our teams are working, I know, incredibly hard. But just for people on the call, the challenges that your hospitals are facing, getting back up to capacity, given the way everything was stopped, and then these new protocols have got into place, are not insignificant. They are very substantial. So it will take a significant period before all of the acute sector is running as it used to in the pre-COVID world.
Thank you, Russell. And can I welcome the new ward and theatre at George Eliot to add to our capacity and the service to the residents in that area. And well done to you and your team for seeing that is there.
So Captain Tom's ward, Les.
Indeed.
Captain
Tom's ward, indeed. Dame Stella.
Just to endorse what Russell has said, really, an awful lot of work going on, some good progress on things like cancer operations and so on. But as Russell says, it's a big logistical exercise. But what I can assure people, particularly councillors who are representing the public and so on, is that there is heavy duty monitoring and tracking of the amount of services and what we're trying to get back up and running, while combining the levels of infection control, green pathways, and all of those kinds of issues that Russell alluded to. So we will keep going on. We're aiming for what the government is aiming for, which is 90% by October and all the rest of it. But it is extremely challenging, and I don't think there is enough understanding at a governmental level about what it actually means on the ground, particularly when different hospitals have got different kind of buildings and dynamics. Those of us with some more modern hospitals in some ways have got some advantages over those. I'm not talking about in Coventry and Warwickshire, I'm talking about elsewhere, where they've got significantly older buildings with a lot more challenges even than we've got. But certainly to endorse exactly what Russell has said, in the sense that there's an enormous amount of energy going into it, and that will continue to be applied. And obviously where we can, we are using digital services, particularly for outpatients, but on the understanding that there are some patients you cannot see digitally and you do need to see them in person, the same kind of dilemma as GPs have got. And similarly, they are making sure that they see people who need to be seen, but equally deal with those who can be dealt with digitally. And we're in the same position. Thank you.
Yes, yeah, thank you for that, Deb. And certainly echo your remark that does the government actually understand what all of us are doing out here? I don't think so. So, Chris.
Just to perhaps add to what's been said, I think it's a paradox in the NHS in the sense of COVID-19 has almost changed everything, but actually it's changed nothing. And what I mean by that is the priorities that we were working on before COVID remain the priorities we're working on post-COVID. And I'd say two things in particular: the differential impact of COVID on different parts of our community, and the exposure of the inequalities in health of many different kinds really reinforces the importance of our partnership through the Place Forum and through the Health and Care Partnership Board. We can't deliver the improvements in health outcomes and the reduction in health inequalities within the NHS without that partnership with local authorities and the voluntary and community sector. And the second sense is we know we need to have care that is much more joined up and integrated. We saw that, didn't we, in the relationship between hospitals and care homes and community services during of that first wave, with those great examples like discharge to assess. So I think it redoubles the importance of the prior commitments we had, as well as giving us some additional challenges to add to the mix.
Thanks, Chris. And I think that Nigel, you wanted to add.
I did, although when Chris got to his final sentence, I think he really said what I wanted to say, which is that while it is absolutely true that the priorities have been that are unchanged, they are the same things. There are some of them which to some extent are exacerbated and where we need to redouble our efforts. And I think mental health is a particular one that falls into that category. But I also think there are some which have had a light shone on them in a way that hasn't been. We've known about health inequalities and we've known there's a need to address health inequalities for a very long time, but actually there has been a real focus on that and a real awareness that actually we can't talk about it. We have to do something about it now. And I think that that if anything good comes out of this whole thing, perhaps that is the one thing.
Thank you, Nigel. Which takes us nicely back to where we started our strategy, which is we need to get it to involve all of those items and encompass them, so it actually helps us to get it right and do exactly what we all wish to achieve. So thank you all very much for that. If we could move on to item 14, which is our forward plan. Any comment from anyone? No, we'll take that as read. So that brings us to the end of the meeting. So thank you all very much. It's been a long meeting. It's been a very productive meeting. It's been a great partnership meeting, and we'll see you next time. And just thank Gemma and Catherine for helping us put this all together. Thank you very much, and thank Paul for monitoring the meeting. Judith, did you want to comment? Judith?
No, I just want to say, well chaired, Chair. It's hard keeping it going for 2.25 hours, but you've done us proud. Thank you.
You've all done very well. You've been very good. Thank you all very much, and see you next time. Paul, you and I will stay online and have a chat.
Thanks, Les.
Thanks, everyone. Thanks, Russell.